Dear Tiang Tao, thank you very much for the introduction, ladies and gentlemen, dear friends. Our topic today is the new trends and problems of TAVR in patients with a high risk. And our particular emphasis in this respect is the incidence of cerebral embolism and complications arising from this complication. Now, cerebral embolism still remains a very frequent problem. These are data from the US-American pivotal study, and they show that there is a 17% stroke rate in this particular patient complication population. And this 17% stroke rate leads to a mortality which is 2 to 3 times above the average mortality for TAVR. These data are showing a meta-analysis. More than 10,000 patients have been combined and collected for this study, and you can see the results with regard to mortality. The green column, these are patients without a stroke. The blue column, these are the all patients taken together. In the red column, these are patients who suffered a silent or a clinically apparent stroke during the TAVR treatment. This is the 30-day mortality on the ordinate, and you can see that the mortality in patients having suffered a stroke is more than 3 to 4 times as high as in patients who do not have a stroke. Now, where does this stroke come from? Where does it arise? There are several possibilities where the emboli can arise from. The most frequent place, of course, is the calcified aortic valve, shown here in this frame, and you can see there is sufficient calcium around and on the leaflets, which may be mobilized by implanting the percutaneous device. Also, emboli arising in the aortic arch are quite frequent, but there are more places. For instance, foreign material can be introduced by the percutaneous device, and there are even sometimes emboli arising from the myocardium after it has been injured by the percutaneous device. So there are quite a few options where the emboli may come from. Patients with a clinically apparent stroke, they are actually not so frequent. Yeah? This is like the iceberg, where only about 20% are above the average, the surface, and 80% of the iceberg are down below the surface of the sea. So only 20% of these patients show clinically apparent signs, whereas the majority of patients, they have clinically inapparent strokes. Now, this is not a harmless problem, you know. Even patients who have an clinically inapparent stroke, they have a 2 to 4-fold risk of future stroke. They have a 3-fold risk of mortality and a 2-fold risk of dementia. On the right side, you see all the studies which have been performed to look at the frequency of cerebral emboli, and you can see there is at minimum of 60% of all patients have suffered a clinically apparent or clinically inapparent stroke during this procedure. In this slide, in this frame, we have superimposed 100 frames of patients, MRI frames, which have been collected on patients undergoing percutaneous valve replacement. On the left side, you see the control group. These are patients who have been treated without a filter, and you can see that there are many red dots throughout the brain. These red dots, they stand for a clinically inapparent stroke. On the right side, you see the patient population with a fully protected areas and patients where the filter has been used, and you can see there are still many red dots and many yellow dots, you know, standing for clinically inapparent or apparent strokes, but they are significantly less than on the left side where no filter has been used. Now, what sort of material are we dealing with? These are the various materials which have been collected during the clean TAVR study, which has been conducted in Leipzig. And you can see that there is calcium, there are pieces of the arterial wall, there is acute thrombus, organized thrombus, valve tissue which has been ripped off from the native valve, and polarized foreign material. So we're dealing with many different forms of foreign material which has to be taken into account when we're trying to protect the patients from this complication. These materials do not usually stem from one single source, but they more or less come from various different sources, and usually it's a combination of locations and a combination of the different types of materials which we find in this area. Now, in order to prevent strokes in these patients, many different devices have been developed or are presently under development. The well-known device is the Claret Medical or Sentinel device, which consists of these two filters. This device actually captures the foreign material and removes it effectively from the circulation. There are other devices, the Keystone Tri-Guard, the Edwards Umbrella, the embolic device, and the transverse point guard device. Most of these devices actually deflect the emboli downstream. They are not removed from the circulation. This is also true for this device, but here the ICI's embolic device, this also captures and removes the emboli from the circulation. Here you can see the Claret device in close up. You can see the two filters. See it a little bit better in this frame. You can see the two filters which are fixed on the same rail, and the proximal filter is deployed in the intermediate artery, and the distal filter is deployed in the left vertebral artery. Here you can see the two filters in position. This is during the implantation of the percutaneous device, and these two filters actually protect the circulation from this complication. This is the study design of the clean TAVR study, which has been performed between 2014 and 2016 at the University of Leipzig. It has been a randomized study, but a monocenter. Only patients which were treated at the University of Leipzig Heart Center have been collected for this study. These patients were randomized into a control group which has been treated without a filter, and a filter group which has been treated with a Claret filter device. 2 days after implantation of the percutaneous device, MRI was obtained, and this MRI was repeated after 7 days and after 30 days. These are the two endpoints. The primary endpoint was the numerical reduction in positive post-procedure diffusion weighted MRI, and the secondary endpoint was the serial volumetric and numerical reduction in the positive post-procedure MRI scan. Here you can see the results of this investigation of the imaging. We're looking at the total lesion number, that's the primary endpoint, and we're looking at the number at 2 days and at 7 days. The yellow columns are the control patients, and the green columns are the treated patient group receiving a filter. This is after 2 days, and here after 7 days. And you can see that there is a highly significant reduction with respect to the total lesion number for both times, for 2 days and for 7 days. These are patients where only the protected regions were evaluated. On this side, all regions available have been evaluated. You can still see that the difference has become a little bit smaller, but it's still highly significant between 2 days and 7 days. Now this is the secondary endpoint where we evaluated the lesion volume at 2 days and 7 days. The graphs are of the same character. The control patients are shown in yellow, and the treated patients are shown in green. And you can see again that there is a significant reduction with respect to the lesion volume in patients having undergone percutaneous TAVR. These are the protected regions, and these are patients where all the regions were evaluated. And in all cases, we can see the reduction in the lesion volume. So, looking at these results, we can say that in patients with severe aortic stenosis who are at increased surgical risk, the use of the Claret dual filter cerebral protection system during TAVR significantly reduces the number and volume of cerebral lesions as determined by MRI. But as this was only a monocenter study, only conducted at the Leipzig Heart Center, of course we were looking for a more comprehensive study which has been conducted in the United States and in Germany. And this is the Sentinel study design. Again, patients with symptomatic aortic stenosis were recruited for this study, and the patients were randomized into 3 arms. There was a safety arm where we only looked at the safety questions. You know, we did not do any imaging studies in these patients. And then there is the test arm where patients were collected who underwent TAVR with the Sentinel device in place. And then there is the control arm on the right side. These are patients where only the TAVR has been performed, but without the use of the Sentinel device. Clinical follow-up was the same for all of these patients, and there was histopathology and morphometry performed in all of these patients. And of course, in the 2 groups, there were serial MRIs obtained after implantation. And there was also a neurological workup done by a neurologist, which is very important. Now, these are the major results shown in a very compact form. There was a trend for the frequency of new lesions in the control arm and in the safety and device arm. However, this difference between the 2 arms did not reach the significance level, which was quite disappointing. There was also no difference with the Sentinel access device complications. And we were looking at the safety question and at the efficacy superiority question. And we could see this 42% reduction. However, this reduction did not reach the significance level. So this is at the present stage we are left at. We have 2 studies, one monocenter study and one multicenter study. In both studies we have a strong trend or even a significant trend in the Claret study. However, in the multicenter randomized study, the level of significance was not reached, and therefore we have to look for new studies and see if we can make any improvements on this. Thank you very much.